Good morning and Assalamu alaikum. Today we will start with a new topic that is related to the bladder cancer. We will have a brief discussion on epidemiology, clinical presentation, and evaluation of it. It is one of the commonest oncological burden in the field of urology. Yes, doctor.
Assalamu alaikum, everyone. Today we start bladder cancer. I will discuss epidemiology, clinical presentation, and evaluation. I am Dr. Hamza Abdul Malik, and my moderator is Dr. Usman Kumar. So, start from the introduction. Bladder cancer is one of the most common malignancy of the unit tract. Tobacco smoking is the most common risk factor, and the great majority of the neoplasm are epithelium, and the more than 90% are the urothelial tumors. Today, our learning objectives are the epidemiology, risk factor, clinical presentation, and initial evaluation. Before we start on the learning object, first we discuss about the anatomy of the bladder. As we know about the bladder is the hollow organ which present in the lower abdomen, which it receives the urine from the both kidney via ureters. Grossly, we divide into the five layer. There is the urothelium, lamina propria, muscular destructor muscle, and the serosa, and the perivesical fats. Bladder receive the blood supply from the superior, middle, and the inferior vesical artery, which arise from the internal iliac arteries. It also gives take from small branches from the obstetric and the inferior gluteal arteries. In female, it's also received from the uterine and the vaginal arteries. The complex of the venous complex of the bladder is ultimately drained into the internal iliac vein. For the nerve supply of the bladder, sympathetic and the parasympathetic and somehow the somatic nervous system are involved. And the lymphatics are drained into the external iliac, internal iliac, and the common iliac lymph nodes. Receptor of the bladder on the blood is the muscarinic, beta adrenergic receptors, alpha receptor, and the nicotine receptor. Sympathetic system is involved in the storage and the retention of the urine, and the parasympathetic system involved in the voiding. Bladder tumor staging, we know TM staging start from the TX, then the primary tumor is not assessed T naught, and no tumor is assessed for TA, the non-invasive urothelial carcinoma in situ, TA, T1 disease when the lamina propria is involved, T2 when the muscle is involved, superficial and the deep, T3 when the perivesical fat is involved, and the T4 when the localized disease is present. Here with the stage 0, as shown in the diagram, when there is a non-invasive papillary carcinoma and the carcinoma in situ. T1 when it's involved the lamina propria, and T2 when it's involved T2 disease when it involved the retractor muscle, superficial and the deep, TE1A and T2B. When it involved the perivesical fats, is T3 disease, and the 4 when it's metastasized locally and the systemic. Epidemiology incidence of the bladder cancer is the second most common cancer of the genital urinary tract and the 10th most common in the malignancy worldwide. It accounts for 7% of the new cases in the man and the 2% in the woman. The incidence is high in the whites than in African Americans. Most common malignancy is the urothelial carcinoma, which is historically type. The United States dominant is the urothelial carcinoma. The rest of the world, the Middle East, and the non-urothelial histology are the more frequently. Here we're showing the worldwide the burden of the bladder cancer, more than 5 lakhs the new cases per yearly diagnosed, and more than 2 lakhs deaths in diagnosed in 2020. And the worldwide age standardized into 9.5% for the men and the 2.4% the woman case noted. And 1.6 million people lives with the bladder cancer worldwide. In 2018, data international data showing the Pakistan burden bladder cancer on the 8th number, and now in 2020 is reaching the 10 number rank on the 10. The more than approx 50,000 cases per year diagnosed, and the average death rate is 0.4% risk rate, and the rank now is the rank on the 10%. Here is showing the worldwide the more in the Americans and the less in the Asians. The risk factors are the divided into the behavior, chemical exposure, chronic infection, nitrogen, and the occupation. If the person is doing the smoker and the drinking the arsenic waters and the bladder calculi and the chronic bladder infection, urinary tuberculosis, and the long-term catheterization and schistosomiasis infection. Also, issue the chemotherapy of the cyclophosphamide and the radiation therapy and the exposure of the aromatic amines and use them, which is used in the manufacture of the chemical dyes and the pharmaceutical gas treatment plants. In smokers, the cigarette smoking increased the bladder cancer 2 to 4 fold, and 30 to 50% of all bladder cancer is caused by the cigarette smoking. And the period, latency period is approximately 28 to 30 years, and the increase the intensity and the increase the duration with increased risk factor. If any patient quitting the smoking, the immediate decrease is approaching baseline after 20 to 30 years, and the tobacco increase is on the threefold versus the brown tobacco. Unfiltered cigarette more increases of the bladder cancer. Deep inhalation also increase the risk of the increase 30 to 40% versus non-inhalation, and the pipe smoking high increase, and the snuffing chewing no elevated increase.
Excuse me, Dr. Fahad, do you have any idea how the smoking is a risk factor, how it causes a bladder cancer?
Sir, it causes a bladder bladder mucosa irritation and chronic inflammation.
Okay, Hamza, go on.
So the occupation exposure in the aromatic amines, the polycyclic aromatic hydrocarbons, and the chlorinated hydrocarbons account for the 10%. This type of the occupational exposure occur mainly in the industrial plants which process paint, dye, material, and the petroleum products. Here, the infection of the schistosomiasis, and we divide in the 5 species of the schistosomiasis. And the schistosomiasis japiconium, schistosomiasis hematobium, schistosomiasis mansoni, schistosomia mcconji, schistosomiasis anticulum. But the hematobium schistosomia is causing the bladder cancer. Here, the cycle of the schistosomiasis, the infective egg release in the urine and the feces, which this infected eggs then enter into the snail tissues and convert into the marsidia, and then this marsidia and convert into the sporocytes in snail, and then it convert into the cercaria. With this cercaria is ready for the penetrate into the host. This cercaria penetrate into the host, and then in present in the host, it releases its tail and move into the circulation and go into the portal system and the bladder venules, which cause the bladder cancer. More than and then this infection is the schistosomiasis endemic in the many of the 76 developing countries, and infected up to the 218 million people worldwide, according to 2017. If we discuss the bladder cancer difference between the gender, there's a man and the woman. There's a man are the 3 to 4 times more likely to develop bladder cancer. The median age in the man is 69, whereas in the woman is the 71%. This might be related to the difference in carcinogen exposure, routes of the entry, enzymatic process, and the environmental substance, and the cellular and the physiological response. But the poor prognosis in seen in among women. On the rational difference, the white Americans are twice as likely to develop bladder cancer as compared to the African Americans and others. The women and non-white American report in more advanced stage higher mortality rates. In genetics, the most studied genes associated with the bladder cancer are N-acetyl transferase 2 and the deletion of the glutathione S transferase. This enzyme is involved in the metabolize of the aromatic amines. If this enzyme is deficient, then there's a chance of bladder cancer. And the loss of the genetic material is seen in the chromosome 9 appear to be consistent, finding the patient with a low grade and the low stage, high grade, high stage disease. If you see the hereditary, the first degree relatives are more twofold increase the developing of urethral bladder cancer, and high A risk bladder cancer are the families are exceeding rare. Lesion syndrome is related to the increased risk of developing in the urethral cancer. And other effects is the Crohn's cystitis, human fibrin infection, upper urinary tract cancer, bladder augmentation. Prolonged studies is showing the bladder augmentation patient due to the increased catheterization and bacteriuria, which cause of the bladder cancer. If any patient the history of the radiation therapy, cyclophosphamide. Some of the studies showing the cyclophosphamide, the patient take a chemotherapy of the cyclophosphamide, have a chance of bladder cancer, and the diabetic related the thiolinsadinase. The study showing some of the this product cause bladder cancer. Pathology, some of the pathology of the bladder cancer we discussed here. That a tumor of the bladder each with its own clinical presentation and disease burden. Start from the normal pathology. It is showing the normal urothelium is composed of 3 to 7 layers of the transition epithelium resting of the basement membrane composed of the extracellular matrix and the collagen and the glycoproteins and the glycoaminoglycans. It is showing the this purple color is rich due to the cytoplasm and the and the nucleus, and the less of the collagen is here, and then is the lamina propria, and there is showing the uterine muscle of the normal epithelium histologically shown, and here is the serola. Uh, Papilloma, the worldwide organized papilloma is the tumor with the fine fibrovascular stars supporting epithelial layer of the transient shell with normal thickness and the cytology. These are also termed the papillourethral neoplasm of the low malignant potential, and a rare benign condition that not aggressive therapies. Transition cell carcinoma, approximately 90% of the bladder cancer are transition cell carcinoma. This tumor most commonly appear as a papillary exophytic lesion, and commonly maybe less. They may be sessile or the ulcerated, and the former group the superficial nature, and the sessile growth are often invasive. Carcinoma is is recognized in the, as a flat and a plastic epithelium, and the urethral lake of the normal cellular polarity, and the cell contain large irregular hypochromatic nuclei with the prominent nuclei. In non-transition cell carcinoma, the most common are the squamous cell carcinoma, which we count is the 5 to 10% of the bladder cancer. Is reported in the United States and associated with the long history of infection with calculi, the patient, and the long catheterizing history, and the history of the infection, like we discussed before, schistosomiasis, hematomia, mebium. And approximately 60% of the bladder cancer in Egypt, part and Africa and the Middle East is where this infection is frequent. In histologically, appear the poorly differentiated neoplasm composed of the polygonal cell with the characteristics of intercellular breaches. Clinical presentations. Most of the patient present with the painless gross hematuria is present in 85% of the patient with newly diagnosed bladder cancer, and the microscopic hematuria is present in nearly all patients. Hematuria, the most common presenting symptoms is hematuria. Approximately 50% of patients with gross hematuria have an identifiable cause, and risk of the malignancy in this patient is 20.4%. Pain associated with bladder cancer is usually the result of locally advanced or metastatic tumor. Its distribution is related to the size and location of the primary tumor and its metastasis. Also, the urethral obstruction, bladder autosuggestion, and the locally advanced and the metastatic disease may cause pain. Widening system most commonly seen in the carcinoma in situ, and resulting in the functional decrease in the bladder cancer due to the overactivity, invasion of the trigon, or the obstruction of the bladder neck and the urethra. Initial evaluation start from the complete history, physical examination, laboratory studies, imaging, and the cystoscopy. If any patient come in AR and the OPD basis, we start to complete history of any history of the smoking, any hereditary history, and related to the industrial work history in the petroleum and the industrial and the dye work, like, and the physical examination, check his meat test for to rule out the any trauma and other cause of the hematuria. For the laboratory tests, who did the districts cytology of the urology and the baseline test. Urinalysis should be include the microscopy and the gross examination, well as a deep stick test or the chemical test. Urine cytology the urine cytology involve the microscopic evaluation of the voided urine or bladder washing specimen for the exfoliated cancer cells. This is essentially, and the specificity of the urine cytology is detecting the bladder cancer is 31 to 62%, 94 to 100% respectively. We use the Paris system of the urine cytology for the diagnosing the abnormal cell. If any patient with the came the negative cystoscopy, but the urine cytology is frequently positive, then best is we do the random biopsy.
बीच में आप क्वेश्चन रेज कर सकते हैं, कर लें सर, प्लीज। What is the reference of this urine cytology outcome 31 to 62% and 94 to 100%?
This figures is showing in
Reference.
Campbell, sir.
I don't think so. This is not a simple outcome of urine cytology, a simple cytology. This is a urine cytology with DNA ploidy. If you do flow cytometry of the urine sample, only then you can have up to 60% specificity or sensitivity up to 94 or 96%. Otherwise, simple urine cytology diagnostic yield is not more than 20%.
So I rechecked, but in this figure right down in Campbell.
I like to see Usman sahab. Yes. ऐसा है mention है किताब में? I don't think so, because the least reliable thing in the curriculum of bladder tumor or any tumor is cytology. And here you show even urine cytology biopsy results are not like 100% or 62%. So how come cytology becomes like this? So we have to review this statement.
Sir, urine cytology, as it mentioned in guideline, that it's showing 84% sensitivity and only in high grade tumor.
But urine cytology with DNA ploidy, if you do flow cytometry of the urine cytology, just by microscopy, you cannot say up to of that limit of 64 or 84%. I agree. DNA ploidy is one aspect of the urine cytology, where not only with the simple microscopy, people used to weld the DNA ploidy with the use of flow cytometer. अच्छा, इसमें आप ये भी बता दिया करें जैसे just for general knowledge कि how we send a sample for the urine cytology.
So approximately we never send approximately 25 ml urine you take and not for early morning urine for the urine cytology.
It should not be a stored sample, either 5 ml or 500 ml, it doesn't matter, because you have to centrifuge all that amount. Ideally, patient should not have UTI, culture should be treated, and the sample should be fresh one. जिस तरह से हम बहुत से सैंपल 24 आवर कलेक्शन करा देते हैं तो उसमें वो यूजलेस हो जाता है. Yes. Sorry. Yes.
It's true that it is recommended in guidelines that we should take to approximate 25 ml for urine cytology, and that should be the fresh and not in the morning sample, because of the lysis of the urine take place in morning, so it should be avoided. And the one thing can I add that in the diagnostic purpose, the gold standard is the cystoscopy, but urine cytology is the adjuvant to the cystoscopy, but it's less sensitive and is indicated in those cases where cystoscopy done and we found any abnormality in cystoscopic finding, but just to see the upper tract symptoms, to rule out upper tract as well as carcinoma in situ and prostatic urethral. So cytology should be done, but is at least insensitive.
In the microscopic high-grade urethral carcinoma display chromatin and the nuclear membrane irregularity. Some of the biomarkers we use for the diagnosis of the bladder cancer, which is low sensitivity of the urine cytology, as mentioned. But also this figure is showing it Campbell respectively the 96 over 6. I will show you. Uh, Urine marker are useful to just say in selective patient, all the lack of the diagnostic accuracy and required to replace the cystoscopy. There is the NMP22 and the beta A UV test, and the biomarker we use nowadays for the bladder cancer diagnosis. Oh, sorry. With the recommendations for the non-invasive muscle cancer, the once the bladder tumor has been detected, to perform the CT in selected cases and perform cystoscopy in patient with the symptoms suggestive of the bladder cancer or during the surveillance. It cannot be replaced by the cytology or any other non-invasive test. In man, use flexible system is available. Describe all microscopic features of the tumor size, number, and the appearance and the abnormality. During the cystoscopy, use a bladder diagram. Use voided unit cytology as an agent to the cystoscopy to detect the high-grade tumor. Perform cycle at least 25 ml fresh urine or urine with adequate fixation. Morning urine is not suitable because of the frequent presence of cytolysis.
So we have seen the cystoscopy is a sort of gold standard in diagnosing the bladder tumor. Other investigations like CT scan or cytology or biomarkers, sort of fancy things, they can help you adjuvant the diagnosis or make you plan a bit, but cystoscopy remains the gold standard.
So I didn't see any flexible program you are using, but I see in my GSL rotation they were using for CBD, looking into CBD. But here was mentioned that men should be used flexible cystoscopy. Is there any difference between men and women?
No, I think the flexible cystoscopy can be done in both males and females. It's the benefit of flexible cystoscopy. It can be done as a office in a OPD basis. When you have patient has when you have a doubt, you can just look at it and do a diagnostic cystoscopy. If you find any bladder tumor over there, then you have to plan it under GA with a rigid one, or because you cannot resect the tumor conventionally with a flexible scope.
So, if any patient with a history of hematuria start from the diagnosis of the bladder history, after taking history, we do first ultrasound. And this is showing the hypoechoic lesion in the base of the bladder with moderate sensitivity to wide range of abnormality of the upper and the lower tract to rule out any abnormalities. CT urography is used to detect the papilloma in the unit tract and indicate the filling effect and any hydronephrosis and the extent of the bladder cancer.
Okay, if the patient is suffering from carcinoma in situ, the CT scan finding may be normal in that patient, because carcinoma in situ does not have any projections, or you may miss carcinoma in situ on CT scan.
MRI is as reliable as a CT for the staging of an invasive and the local advanced disease, and there may be a better evaluation tumor at the base and dome of the bladder. Gadolinium enhanced MRI may be superior or to CT to detect the superficial, the multi-tumor, extracervical tumor extension, and the surrounding of organ invasion. as we discussed before, the cystoscopy is the gold standard. Cystoscopy is the gold standard for the initial diagnosis of the bladder cancer. Cystoscopy is combined with the unit cytology, which may be a direct lesion that might be missed at cystoscopy or lesion of the upper unit tract arena, and the diagnostic. It's used for the diagnostic and the therapeutic surveillance. Here there are some of the new techniques used for better for the better result of the cystoscopy, and for the more non-invasive tumor diagnosis is the blue light cystoscopy performed using the white light after the intravascular inhalation of the 5-aminophylline acid and the hexamylovine acid. Some and the other is the narrow band techniques, which to more accurate to visibility of the bladder vessel, enhance the visualization of the tumor, potentially improving the outcome of the TURBT. Narrow band has been used to the alternative approach in an effort to improve the result of the cystoscopy. Some of the
and deep blue light or the ultraviolet lights are not available with the flexible. So one of the limitation of flexible is like
other new modalities are the Octa and the species, which more in specialize the novel endoscopic image technique with different modalities, and the corona enhance the sharpness of the display image, and the more adaptation of in the image in the achieve clear visibility in the dark region. TURBT is the transection, the initial treatment of the presumed non-invasive the muscle invasive bladder tumor is the complete transverse resection of the visible bladder tumor with adequate depth to include the muscular propria. The quality of the TURBT is of primary importance. So what are our goals for when we're doing the TURBT? Sexual TURBT should be identify the factor necessary to assess the diseases, clinical staging, adequacy of the resection, and the presence of the complication to measure the size of the large tumor, describe the characteristics of the tumor.
So, cystoscopy or TURBT or endoscopic dissection is diagnostic as well as therapeutic for the patient.
So, what are the points of our presentation? Is the bladder cancer is related to age and the exposure of the environmental carcinogens, and smoking count to 30 to 40% are usually carcinoma. Bladder cancer is more than 3 times as prevalent in men, and women are more likely seen initially with more advanced tumor and less favorable prognosis. Bladder cancer is the most expensive cancer to treat per patient over patient lifetime. No dietary intervention have been successful to reduce the risks from the bladder cancer. Painless gross hematuria is the key presenting symptoms of the bladder cancer occurring in 85% of newly diagnosed patients. A full hematuria evaluation of the bladder cancer include a focus history and the physical and cystoscopy, upper tract image, and the urine culture. The gold standard test for the diagnosis of the bladder cancer is the cystoscopy and the biopsy. Increasing the LHA, VLC, and the narrow band imaging are being used as the agents to cystoscopy in identify the occult malignancy. Thank you.